If you open a clinical treatment guideline for syphilis, it is easy to develop a strange illusion. The treatment looks so simple that it almost feels like anyone could do it. The logic is straightforward and almost brutal in its simplicity. There is no need for expensive new drugs, no complicated combination therapy. In fact, it still relies on something that feels almost old-fashioned: extreme sensitivity to penicillin. In many cases, a single injection of long-acting penicillin is enough to clear the pathogen completely. In other words, inside the hospital, syphilis behaves like a remarkably weak opponent. From a pharmacological perspective, it appears to be one of the least threatening sexually transmitted infections imaginable. And yet, this very disease keeps coming back again and again in an era where antibiotics are highly advanced. It has become a persistent headache for public health systems in many developed countries, with infection rates rising in recent years. So what makes syphilis so difficult to eliminate? If we imagine infectious diseases as a massive survival game, many pathogens behave like powerful bosses that constantly evolve new abilities. Just as medicine finds a way to counter them, they mutate, develop resistance, and force doctors to upgrade their tools again. They seem to exist in a constant arms race with medical science. But the bacterium that causes syphilis, Treponema pallidum, plays a very different role in this game. It resembles a beginner-level enemy. It has few tricks, weak defenses, and can be defeated with the most basic attack: ordinary penicillin. Penicillin works by disrupting bacterial cell wall synthesis. Many bacteria survive by developing countermeasures, such as altering target sites, producing enzymes that destroy penicillin, or activating drug efflux pumps. Treponema pallidum has done almost none of this. While many bacteria became resistant long ago, this organism remains unusually sensitive to penicillin, like a relic from another era. By logic alone, this should be an easy opponent. The pathogen enters the body, symptoms appear, the patient seeks care, treatment is given, and the infection is cured. In theory, with aggressive enough treatment, syphilis might even be eliminated entirely, the way smallpox once was. From the perspective of whether medicine can kill the pathogen, syphilis has never been a difficult disease, but reality tells a very different story. Today, syphilis remains one of the most challenging problems in both clinical medicine and public health. According to global disease burden estimates from the World Health Organization, there were approximately 7,100,000 new syphilis infections worldwide among people aged 15 to 49 in the year 2020 alone. For comparison, new human immunodeficiency virus infections in the same period were about 1,500,000. The impact of mother-to-child transmission is equally alarming. Modeling estimates from 2016 suggest that congenital syphilis contributed to roughly 661,000 adverse pregnancy outcomes, including around 200,000 stillbirths or newborn deaths. If this sounds like a problem limited to countries with weaker healthcare systems, that assumption would be wrong. The data from developed countries is just as concerning. In the United States, surveillance data for sexually transmitted diseases in 2022 reported approximately 207,000 syphilis cases nationwide. About 59,000 were in the most infectious primary and secondary stages. Even more striking were nearly 3,800 cases of congenital syphilis, with numbers continuing to rise in recent years. This means that even in a country with well-established prenatal care, more and more infants are being born into an infection that should be preventable. Japan tells a similar story. National surveillance data show that in 2022, Japan reported roughly 13,000 syphilis cases, the first time the number exceeded 10,000 since modern reporting began in 1999. In 2023, cases surpassed 15,000, setting a new record. In 2024 and 2025, numbers remained above 13,000, still hovering at historically high levels. These figures force a difficult question. Why does a disease that can often be cured with a single injection of penicillin continue to resurface in modern societies? The answer is clear in one respect. Even in places with abundant medical resources and easy access to antibiotics, syphilis can still push public health systems into crisis mode. Unlike pathogens such as gonorrhea, tuberculosis, or drug-resistant staphylococcus, which evolve rapidly and require constant medical innovation, syphilis has a different strength. Its greatest weapon is invisibility. It hides in the shadows, stretches the timeline of infection, and stays off the map for long periods. By the time medicine realizes where it is, the opportunity to stop transmission has often passed. In the early stages of infection, many people have no symptoms at all. Others may notice only a small, painless skin lesion known as a chancre, which rarely raises alarm. Even when someone senses that something might be wrong, the lesion often disappears on its own. Later, symptoms such as rashes, fever, or fatigue are easily mistaken for a cold, an allergy, or simple exhaustion. Then comes the latent stage, which is so quiet it feels as though nothing ever happened. But the pathogen never left. It can remain in the body for years, waiting to reappear as severe organ damage. This is why clinics repeatedly encounter the same frustrating scenario. Patients do not come in asking to be treated for syphilis. They come in for rashes, hair loss, vision changes, neurological symptoms, or unexplained pregnancy loss. Then, buried in the test results, a positive syphilis result suddenly appears. In one sentence, syphilis symptoms are subtle, intermittent, and deceptive. Disease is most contagious when it is least noticeable and most noticeable when it is already late. The clinical course follows a relatively fixed timeline, progressing through primary, secondary, latent, and tertiary stages. Primary and secondary syphilis together are known as early syphilis, the most infectious phase. Weeks after infection, a painless ulcer may appear and then heal on its own. But healing does not mean eradication. It simply means the immune system has temporarily suppressed the pathogen. The bacteria continue to spread throughout the body. During secondary syphilis, systemic symptoms appear, including rashes, mucosal lesions, swollen lymph nodes, fever, and fatigue. These signs are obvious yet easily confused with common illnesses, which is why the disease is often ignored at its most infectious stage. After early symptoms fade, the infection enters the latent phase. There are usually no clinical signs, but blood tests remain positive, and transmission may still occur if the infection remains untreated for years. A minority of patients progress to tertiary syphilis. Sexual transmission is rare at this stage, but blood and mother-to-child transmission remain possible. Organ damage can be severe and irreversible, affecting the heart, nervous system, bones, and skin. When viewed as a whole, this timeline explains why syphilis is easy to cure, but hard to eliminate. The core challenge is identifying infected individuals early, treating them promptly, ensuring follow-up, and managing partners to prevent further spread. Since the main problem is delayed and incomplete detection, a seemingly logical solution emerges: expand screening. Screening is already familiar in modern medicine. Conditions such as high blood pressure, diabetes, cervical cancer, and colorectal cancer have been significantly reduced through early detection and early treatment. So in theory, large-scale screening for syphilis should work. Detect infections early, treat them quickly, and reduce sources of transmission. Screening is a common public health tool. Early detection of asymptomatic carriers, followed by treatment and isolation, has been used in many outbreaks. Syphilis appears well suited for this approach. Blood tests are mature, treatment is effective, and early intervention prevents long-term damage. In fact, routine medical checkups, workplace exams, and premarital screenings often already include syphilis testing. The real issue is that effective screening is not a single test. It is a complete chain. High-risk groups must be willing to be screened. Test results must be accurate. Positive cases must receive immediate treatment. Follow-up must be completed, and the surrounding transmission network must also be addressed. If this chain breaks at any point, the entire effort fails. Unlike some epidemic responses, syphilis screening chains are fragile and break easily. One major reason is stigma. Sexually transmitted infections are deeply tied to moral judgment. Infection is often framed as personal failure or moral weakness. While this narrative claims to promote responsibility, it pushes people into silence. Even when testing is accessible, fear of exposure, labeling, or relationship conflict leads many to avoid screening or disappear after abnormal results. This creates a paradox. The people who most need screening and who occupy key positions in transmission networks are often the hardest to reach. Syphilis spreads like a web, not a straight line. The weakest points in the web are not necessarily the most reckless individuals, but those least visible to public health systems, people with poor access to care, people afraid to disclose sexual histories, people relying on anonymous or short-term relationships, people who do not know where to seek help or how to ask. When society forces people to choose between social approval and medical care, silence becomes the predictable outcome, and silence allows infection to circulate quietly, hidden but active. This is why syphilis screening is not about morality, but visibility. It explains why even regions with advanced medical technology experience repeated resurgences. No matter how strong treatment capabilities are, blind spots always remain. And those blind spots are exactly where syphilis survives and reignites transmission. Another challenge is that syphilis test results are not simple positive or negative answers. Interpretation requires confirmation and staging. After treatment, some markers may remain positive for years. These nuances are confusing for individuals and demanding for health systems. Without proper explanation and follow-up, misunderstanding, anxiety, and loss to care are common. Finally, unlike many chronic disease screenings, syphilis cannot be managed one person at a time. It requires addressing entire transmission networks, including partners and families. Once privacy, trust, and complex relationships enter the equation, medicine alone becomes insufficient. Treatment always lags behind transmission. Many people instinctively believe that if medicine is good enough, disease should disappear. But syphilis has never been a battle between doctors and bacteria alone. Medical treatment is not the same as public health control. Drugs eliminate pathogens. Public health must manage societies, relationships, shame, fear, inequality, mobility, and silence. Syphilis acts as a mirror, reflecting the most fragile points of public health systems. It reveals whether a society can safely and respectfully bring those who do not want to be seen or are afraid to be seen into care. If syphilis ever truly declines to very low levels, it will not be because of a new miracle drug. It will be because society learned to reduce shame, protect privacy, improve access, and make it easier for people to walk into a clinic and say something that once felt impossible to say. The return of syphilis is a reminder that medicine can do a great deal, but it is never enough on its own. If you would like to hear more explanations like this, subscribing is always appreciated and discussion is welcome.